from our talk yesterday that would be helpful? Well, this morning I want to talk about effective data use because from my career perspective as an MCH epidemiologist, you heard me yesterday, effective use is really important. In my opinion, there's absolutely nothing worse than for me to do a top quality job on a project, something of even publishable quality, but then have absolutely nothing happen because of it. In fact, when I was over the MCHEPI program, even before then, I was supervising other state assignees. I would come and they said, Bill, I have this really great project, and here are the results. How do I get the program to use it? So I want to talk about that sort of struggle. When you talk about epidemiology, if we talk about our roots, John Last is the only one who I know that's written a dictionary for epidemiology, a substantial publication. And he defines epidemiologists study the distribution and determinants of health-related states or events in specified populations and the application of this study to control of human problems. He talks about it from the application perspective afterwards. Again, the components are frequently descriptive. Determinants are frequently analytics. I would say a lot of it gets to be focused in on creation of new knowledge or confirmation. Now, there's some in infectious disease that are much more related to control, but not necessarily others. In 2000, we formed the Coalition for Excellence in Maternal and Child Health Epidemiology. It's an organization of 16 national organizations who jointly sponsor MCHEPI awards that are given out at every MCHEPI conference. Some more will be given out this coming September. But we had to define what epidemiology was in MCH so that we could give out awards. And we basically said systematic collection, analysis, interpretation of population-based and program-specific health and related data in order to assess the distribution and determinants of health status and needs of the MCH population for the purposes of planning, implementing, and assessing effective science-based strategies and promoting policy development. So we went much further in the sense that it is about the needs of the population. It is about done intentionally for the purpose of planning, implementing, and assessing effective science-based strategy and policy development. So we want to be very clear that it's not just about epi, but it's about what you're going to do with the epi that you have. The idea behind it is that your epi practice really needs to be results focused. And by results, I don't mean epi results. Results focused, I mean it's talking about public health impact. Julius Richmond, who was former Surgeon General and Assistant Secretary for Health, and Milkutachuk came up with this diagram. We use it a lot with City Match. We talk about to have effective change, to move data to action, to change community to health. It really takes three things. It takes a knowledge base. In that knowledge base, we're talking about science, we're talking about epidemiology, we're talking about data. But it also takes an effective social strategy and a political will. And without the three, you can't have change. For example, we know unintended pregnancy is really high in this country. We know a lot of the risk factors for it. We know a lot of the effective social strategies we could do to address it. And what is our political will like right now? We still don't even have Title X on continuing funding. It's on a funding every year basis. So without political will, we can't do anything. Without a strategy to know what works, we really can't do anything. Or we have limited strategies. So what this means to me is if we're going to take on an EPI project, and my intent is to have results, I need to be thinking about these three things from the start. In fact, when I talk about a data use triangle, we talk about the need for data analysis, program planning, and policy. So what I would try to do as an epidemiologist is from the start, when I was going to work on a project, depending on what stage it was at in maturity, I would always try to have program and planning people involved. I would always try to make sure the politics or the policy decision-making were informed and we're going in the right direction, and that we have data analysis. The most classic example I've had in my career where political will mattered was the governor's office convened a group when we had our first drug abuse outbreak during the late 80s, early 90s. This is when cocaine hit. And the governor's office convened 3 groups, one working on how large is the problem, one working on legal issues, and one working on prevention and treatment. I was actively involved in the data assessment side. We actually secured funding. We tested over 2,400 women in 24 hospitals, and we could measure the prevalence of drug use at the time of delivery for 12 different drugs, estimate the prevalence. The legal team worked through all the laws that needed to be done. We've been working with both the prevention and treatment pieces, and these reports were all coming together. We had a 5-volume report that was coming out. The governor's office thought they'd been checking with the governor as they went through this. And we finally got time to release the report and take action, and the governor says, why all this? All we need to do is lock them up. And so we had all these reports. They were all done, but they were never officially released or officially cited because at the last minute, the governor pulled out the trunk. So I try hard not to be in this situation. When you think about your EPI projects, and I start on one, I try to worry about these 3 pieces. Now, sometimes I can't help it. Sometimes I'm working on oral health, and I have a dental health director who acts like they like data. But as I work on a project with them and I get something done that was really good and I give it back to them and they don't do anything with it, guess what I do? I don't work on any more oral health projects. Or if I have someone who's not interested in working on a project, I don't go do a project in that area. What I do is I'm old enough and I've been around long enough, I wait for what I call the right opportunity. Because if I wait long enough, something's going to happen where they need help. And then I can use data and expertise to step in and help them where they are with their issue, which they'll have more ownership of, which creates a better chance of doing these pieces, if that makes sense. So I wait for the right opportunity. Sometimes that means that person has to leave and go on and get a different job. I will tell you that I have many painful situations where we've tried to do this and leadership is not there. And you may not have any choice in your position. You're directed to do something. But I tend to, what I say is look for the right opportunities. And the right opportunities are not necessarily data-driven alone, but are driven by what are the pieces. In other words, if I can visualize what's going to happen because I do this project, then why am I doing the project? Because I will tell you with most data projects, how many can probably predict 80% of the time what you're going to find? I would say in my career, at least 80% of the time, I could have told you the results. So when we're going to work on a project together, I said, okay, when I get this, and this is what I'm going to have, what are you going to do? And they say you're going to do X. And then I'll go back and say, okay, what if I find this other thing? What are you going to do? Well, I'm still going to do X. So no matter what I find, you're still going to do X. So how important is that project? So think through these pieces as you start working through it. The other thing to remember is you always need to be doing this, even though you're talking about you need planning people involved, you need the political pieces involved, your data. It's got to be in the context of the community with which you're in. And that's absolutely essential. Even if it's only a health department project, you need to think about the context you're in. So we talk about the data use triangle. We talk about the need for these 4 people. And we talk about from the building the team from the start. Because if I have somebody who's been involved in the project from the start, do I need them to read the results and the recommendation for them to do something? No, because they've helped you develop the findings and the recommendations. So they know what it means. However, if I wait and go off in my own office and beat on them with it once I have the results, I have to expect them to listen. I expect them to own it. They're more likely to own something they've been engaged in than something you now come in and say, look, this is an issue that we have. The idea Bill Fahey started, a former CDC director and APHA president, called it Consequential Epidemiology. Tom Frieden, the current CDC director, calls something similar what he calls intervention epidemiology. The idea is you're doing epidemiology to make sure there's something going to happen. You're going to intervene. You're doing it with an intentional focus. Gala actually did an analysis. This is something that Ashley put together for us. Did an analysis in 2012 of the 4 leading epidemiology journals and looked at the articles in those journals for that year. And 85% of them were etiologic studies. And only 15% had implications on people's lives. 85% were etiologic focused and only 15%. So would John Snow have been proud of these results? Is this what you call consequential epidemiology? And part of it gets to be is many of you actually trained in departments who focus a lot on the etiologic aspects but don't always relate it to an implication. And again, if we're going to talk about consequences, it goes back to the talk yesterday. You can only do it in the planning cycle. And let's talk about where data is needed. There's 3 areas where data is needed. I do not want to forget in the planning cycle is I need to develop awareness first. I've got to get an issue recognized as a problem before it can be prioritized. So I do say that epi and surveillance and can play a role in creating new awareness. When I went to the Florida, CDC came out with BRFSS, and for the first time in all 50 states, they assessed contraceptive use in all 50 states. And Florida had by far the lowest prevalence of contraceptive use among women at risk for pregnancy through reversible methods. By far, the absolute lowest. And it was 5th lowest on use of sterilization. That meant we had some of the lowest protection for contraceptive use. And so, totally unknown to Florida. Until CDC decided to do this, we had no idea. And I went in and saw the MCH director, and I presented this, and it says, and look at these results. We could actually go to Mississippi and learn how to do family planning, Annette. I can still remember her face when I told her that, because Mississippi was doing actually quite well with their contraceptive use, and we weren't. So we started to recognize contraceptive use as a very important issue. But I will tell you it's slow, because even though I brought it up, and even though I brought it to everyone's attention, it was not getting traction. There's one thing about knowledge, and there's another thing about ownership. Jocelyn Elders, former Surgeon General, had a very famous quote. She basically said, if you haven't told people 20 times, they've not heard you. Say again. If you haven't told them 20 times, they've not heard you. And so what I started to do was unintended pregnancy impacts every MCH outcome you can think of almost, or at least 80% of them. So in almost every presentation I gave, whether it was to doctors, to the health directors, to the department, our state meetings, guess what was always brought up? Our low use of contraception. And finally what happened is, guess what people were starting to do? Talk about contraception. In fact, one of our former state health officers, I was getting up to do a presentation, and he says, Bill, are you going to talk about contraceptive use again today? I mean, they started to just expect that to happen. So awareness is a key role, but it fits into assessment. It fits into monitoring and evaluation. So you need to be thinking when you're working on a project and data, and I'm trying to have intervention, I'm trying to have results. You not only think about the results, but figure out where are you going to connect in and with who for those results to be having an impact. The idea is, where's the baton going to be handed off? The other thing is your expertise is also used in strategies, because most people in your team are not going to be good at assessing the evidence base. So you can also play a unique role there, but it's not one where your data that you're generating will play as much of a role. So again, the key is see the end in mind before you start your project. And so that you don't ever come back to Bill at the end of the project, I have this great result, how do I get somebody to do something with it? Because if you didn't know what someone was going to do with it when you started it, I would challenge you is, why did you start it? Let's talk about some of the 5 common mistakes. My most favorite. Before we break, we're going to let the statistics speak for themselves. It is very common in epidemiology that what we do is we show people the data and we expect them to see the results. What proportion of a general audience, if you show them a graph, can accurately describe what that graph is telling them? Studies have shown less than half. What is the most common graph that people can grasp and understand? A pie chart. How many of our data results actually fit on a pie chart? They've also studied what's the most amount of numbers that an audience can retain. What? It's 5. Well, at least the study I had was 5. You may have a better study. But 5 numbers. Well, how many numbers do you give out in your epi presentations? And then we go, I don't understand why they didn't hear what I was saying or understand what I was trying to communicate. In other words, we can't have the numbers tell them the answers. We need to figure out how to take those numbers into stories or into impacts. We need to say what those numbers mean. I would even go so far as we may even say what we need to do with those numbers once we have them. If you start telling people what those numbers mean, you're going to be invited back to speak. If you just tell them the numbers, guess what? I got invited into South Carolina to come talk to the Medical Advisory Committee. And they said, no, we don't want any statisticians talking to us. We don't want to hear the data. I said, well, let's just let Bill do one presentation. Well, I did one presentation. Well, guess what? I got invited back again and again, and then I became a member of the committee. And they expected me to report every month, every time we met. But the key got to be it's not about the numbers. It's about the messages you're trying to communicate. If you haven't gotten the drift yet, the worst thing you can do as an epidemiologist is go off and do it yourself. We were at a national meeting at CDC, and one of the birth defect directors say, my biggest problem is my MCH director, because every time I try to study, they try to intervene and mess it up instead of just letting me go off and do my study and let me give them the results. Literally said that in a room representing the entire country on birth defects. I'm going, really? Okay, this is the person who's supposed to do something with your data and they're messing you up? Do not go off and do something on your own. To ignore planning. I hate planning. It's not my role. That's your job. Here's the data. Do with it what you want. And you know, that sounds ridiculous, but you know how common I hear that's the biggest complaint from MCH programs? Is somebody just gives them the data. Not the data they want, but gives them a lot of data, gives them a lot of reasons why the data aren't quite right, a lot of limitations, and a lot of cautions on how they can use it. But here you go. It's got to relate to the planning cycle. The other thing that's a painful lesson, but extremely important to know, if you want to take your data and move to results, it's going to take as much time to move from the results to action as it is going to do to generate the results. I'll say it again. It's going to take as longer to actually implement it into action than it's going to be to actually generate the results. And I will tell you, sometimes even the challenges you're going to run into are larger than generating the results. So when you start talking about the data, you can't just hand it off. It was like that contraceptive piece I talked about. I told the MCH director we had the lowest rates. But if I had left it there, guess what? We wouldn't have done anything. But at the time when I brought that up, the family planning program was the stepchild. Because why? It was politically incorrect, and so they were burying it. Well, finally, when they realized how bad the contraceptive rates were, they elevated it up. They made it a priority. When the county health departments were cutting budgets, they no longer said, well, this is politically unacceptable. We were saying, we cannot not fund family planning. In fact, we got to the point the state legislature one year was going to cut 2/3 of the state budget for family planning. And we had developed a policy brief that for the governor's office, they decided not to give because even though other Republican governors were promoting it, they said maybe they shouldn't do that. Well, the Surgeon General, since she couldn't release it, met with the Democratic caucus, the Women's Caucus, and the Black Caucus. And amazingly, all of them stood up in the House and Senate and reported results out of a report that was never given. And that year, we only cut family planning dollars $20,000. Okay? But that didn't happen because I went into the MCH director's office. That went in because we had to bring it up again and again in every context, in every place it related. So they got ingrained into the organization. The other thing is, Mahatma Gandhi said, we must become the change we wish to see. In other words, you need to be believers in using the data you are. In your training program, they taught you to be independent, think independently, pull back. I'm telling you, yes, when you're looking at the quality of the results, you're interpreting the results, you need to come from an independent mind. But once you decide that the results have inference and meaning and implications, you now need to be the biggest carrier of those results. Because no one will understand the results or the importance of the results more than you do. And assume that just because you hand it off to the program person that they can embrace those numbers is wrong, because they don't think about numbers. They're thinking about, I've got this budget and these programs and these objectives and these management issues, and they need someone there to keep their eye on the vision of what needs to happen. So that's really important for effective practice. Does that make sense? Well, when I went on to be the team lead in MCHEPI, this was after 2000, mid-2000s, we funded UIC, Deb Rosenberg, who used to be part of this training group. I think it's before Ash. I think this was before you were involved, Kristen. But they actually did the only detailed study I know of what is effective EPI practice on the applied side, and they did it for MCH. In this project, one of the things is they came up with a framework of how EPI should work. First, you start out, there's a population context and a public health context. And within these contexts, you have health agency structures that everybody needs to use. You have MCH-EPI specific structure. You have MCH-EPI effort processes. Those processes put out outputs that help lead to intermediate outcome changes that hopefully improve health status. So why do we talk about this, and why is this important? Because it talks about the essential elements. You need to have sufficient agency structure. You need to have sufficient MCHEPI structure. You need to have process. One of the other things we discovered is sometimes, sounds crazy, our outputs actually became infrastructure. Can anyone think about what that might be? One of our outputs might be linked data files. But in fact, by having linked data file, they now become infrastructure that we need to do to address projects. The output might be a PRAMS grant that now provides data that we need to actually become an essential part of our program. So there is a loop that goes this way, as well as a loop that goes this way. In that report, they talk about a whole series of steps and pieces in each. I'm not going to go there. But what I do want to talk about is some of the results. They did phone interviews with all 50 states in Washington, D.C., 100% ascertainment. They asked for people for their needs assessment, their block grant, any EPI reports they've ever got published, or presentations, or journal articles that any state had ever done. What they did is they took the 51 areas and then put them out in high capacity, medium capacity, low capacity, and then they went through and looked at factors that were associated with high ability to do practice and low ability. Interestingly enough, what they found out was, one, having an organizational position called an MCH epidemiologist was important. Because back in the early, mid-2000s, there were some states who didn't. Now, most states have somebody in that sort of recognized role. But the idea is it needed to be a recognized function. But even more important was an agenda setting by consensus. In other words, I don't just have an epidemiologist to do the pet projects that I need done. The idea is at an agency level, I have an agenda that's a set that we're trying to carry out so that everyone is going to benefit from what work we do. Because, I mean, there's different levels of work. There's low-level work, medium-level work, and high-level work. And it's by that consensus building that you can move to high level. If you're including external partners, it actually gets slightly stronger, though they're not significantly different. It's important, we actually found that high-capacity states have doctorally trained people. That does not mean that master's prepared people are not important. But from an overall capacity, it takes a mix of skills and ability to function well. High-capacity places have assignees, interns, and fellows. So which is it? Does the high-capacity places attract those people? Or do those interns, fellows, and others help it be a high capacity? We think it's iterative. It's not one or the other. The other is the ability to routinely share data and data integration. The idea is to make data available and not make them silos. And the more available they are, the more integrated they are, the more linked they are, the more effective your data use is. Why do I put this out here? Because when you talk about effective data practice, I want you to realize it's not just about your practice, but it's about your whole effort and what's important. So they came out with some published recommendations to states. You need to have a named unit called MCHEPI. Why? So you have a critical mass focusing in on MCH and not just having one MCH epidemiologist here, one over there, one over there. Because the likelihood of having an agency agenda when they're all over every place and not any one place is very small. Interestingly enough, it didn't matter whether they were in the EPI division or the family health division. It was just needed a unit somewhere. Ensure leadership in that unit has organizational recognition and authority. In other words, it's not just I get assignments and I do them. but you actually have people in position who actually do play leadership and are recognized in leadership, because that's that use piece. It's just about producing results. There is no impact. It's about moving those results to use. Acknowledge a broad scope of collaborative approach. Hire increasing numbers of doctoral degrees. Invest in critical mass of epidemiologists, and pursue assignees, fellows, and training. Provide staff with time and funding for training. That's why this institute continues in training, because training is essentially important for states and communities. Ensure direct access to a wide variety of data sets, routinely link beyond birth and death data, disseminate work using multiple approaches and venues, jointly translate findings into information and action, and support external partners in turning data into information. I don't want you to leave this week just thinking about your role as just you. To be effective using data to practice, it's going to take your whole critical mass of you to make that happen. And it takes a team. Again, it takes those three pieces. And again, I drill this in my mind every time I think of a project. And I would encourage you to think about that every time you start a project. Do you have the critical pieces that you need? Questions before I go into a long example? Yes, ma'am. You need to be contributing to leadership.
Thank you.
You need to be considered a critical person of the team. The idea is if you're the WIC epidemiologist, then you need to probably be at least participate at some level with WIC leadership. Because how can you know what the critical issues that WIC needs data for if you're not sitting in those meetings? And then how can your results from your data be incorporated into leadership decisions if you're not engaged? If you're a WIC epidemiologist sitting in an epi unit and they decide and give you what projects you do and you generate those projects and results, your ability to have impact is small. And the projects that they're going to have you focus in are the little management things that rise to the top, and they're not going to think about how to use data to answer critical questions. Because most program people are not geared to think of how data can feed decision making. There are exceptions to that, and I've had many in my career, but many are not. So I don't assume that anyone understands how data is involved. Now, how I engage that, again, I start where they are. I don't tell them how this data could be used to make that decision. I look to say, what decisions are you struggling with? And then I say, okay, do you think the following data might help you? Well, let me go generate some things and let me get back to you. So in other words, I try to start with programs and people where they are. I don't try to come up with what the best, most sophisticated project that can go off to the MCHEPI conference. I'm thinking about what are their needs, where they are right now, even if their needs, sometimes in my opinion, are not high priority. But if I start meeting where they need, then I'm going to start developing trust. And they're going to start seeing me as having credibility. So once I have credibility and we have trust, then we have the ability to talk about things that are beyond their interest, because I have credibility and I have trust. But until I establish a relationship, they're not going to let you go very far. And if you're starting at a master's, you're starting at a slower pace than if you're a PhD or a physician, because you're going to be perceived as a lesser status. So start with people where they are, because each of you have value. The key is you need to show them how you can help them where they are. And once you can, they're going to come back to you. Or, let's put it this way, If they can't see how you value and you're trying to answer your question, then I move on to somebody else. Because there are some people who just didn't value what I did. They just didn't get it. And my boss would go bananas because she would see exactly what I'm saying. And she would communicate to them, and they still wouldn't get it. And so the key gets to be is I don't want to waste my effort, and I don't want her to waste her resources. So normally I just would move on to where I could be used. But again, if you're patient, the right opportunity will come along, and all of a sudden, I need you. Can you help me? Other questions? That is always a challenge. And I don't think there's a pat answer for it. Part of it gets to be, in my opinion, is you need to get people to have a vision. By vision, the vision's not shared data. The vision is, what do we want to do with our data? What is it, results that we want to have? What are the possibilities? And then have a discussion about how do we get there and what do we need to do to get there? And how do we make that happen? And part of it gets to be is, if you know anything about adaptive change, you have the early innovators, you have the people who are going to be the sort of middle group, and then you have this other group who just doesn't move. In the Department of Health, where I was, we had so many people doing linkage. One of the jobs when I came on board was to work on data linkage. And what we started to do was talk about what we wanted to do, how it would help, how would we get there. And then over a period of about 3 or 4 years, we started doing a library. Now, the library didn't have all the data in the same set because I couldn't get people to do that. They owned the data. But the library got to be, we had one group who agreed to be the primary linkers. Again, people could use someone else, but if you didn't have anyone else, they were the primary linkers. And then 2, they agreed to be the request acceptors. Because before, if you had 3 data sets were linked, that individual had to figure out who in the 3 different programs that you have to get the request to. And you might need 3 different data use agreements to get access to that one linked file. And what they did is they would handle the approval process and work on an agreement that met to everyone's purpose. So we created a vision. We started on a pilot plan, and we moved towards it. Because, again, sometimes a moving ship with small incremental change will help you get further than going for only the big change. Does that make? So I think starting there and having it work and showing people it works well can get other people to play ball. My most favorite is I got a chance to go off to a CDC site visit with an assignee, and the vital records people wouldn't let her have access to preliminary birth certificate data. It's not official. It's not done. We don't want to put out redundant numbers. We only want to put out good data. And so I was there and I said, well, let me show you something. I went on to a website called Florida.Charts. And I pull up a birth query system from the Florida Department of Health. And I click up this query system where we can query about 28 different items on the birth certificate. And it said, oh, and by the way, what you're seeing is data goes through Friday of last week. So the interim or acting state health officer was sitting there, and she goes, wait a minute. Let me understand. You actually put your provisional data out to the public on a website through Friday of last week, and we're sitting in this meeting debating whether our own CDC employee here gets access to use it. I said, yes, ma'am, that's exactly what you're debating. She looks over the vital records people and goes, so please explain to me again why she can't have it? Change is hard. People control data. They have certain philosophies and ideologies. And sometimes you just need to help them get a vision for something different. Does that make? And I will tell you that vital record site drives most state vital records people across the country bananas. Well, when I went to Florida in 2005, when I left CDC, I was 20 years commissioned officer. I can leave as a retirement like the military. I had a chance to sort of re-choose what I wanted to do. I could go off and be, at that time, CDC would not let me stay. If I retired, I could not stay. I had to be there 30 years to retire before I could do that, and I didn't want to wait that long. So I could go off and be what we call a beltway bandit. I could be a contractor who did work for CDC. However, I looked at that, and all they did is the work that CDC didn't want to do. So why do I want to be a contractor doing the work that CDC doesn't want to do? The second, I could go off into academia right away, and most of my colleagues who did spent all their time chasing money to work on any project they could work on, not necessarily what they wanted to. Or I could go work for the state. And I love to work on research and evaluation project that has measurable difference in the lives of moms and children. So I went to work for Florida. And I got there, and they gave me 3 major priorities. One was our infant mortality rate is flat and going up and down. We can't interpret it, Bill, what's going on. Help us. 2, we want to evaluate our Healthy Start program because we want to show how it works. And 3, we wanted to work on linked data files because it's a major issue in our agency. So infant mortality was the less politically sensitive of a topic. And so it was I always believe, by the way, in early successes. If you want to look good, you want to build your trust, you want to build your credibility, always have good, quick projects that will show quick results. If all your projects are long-term projects, people are going to wonder what you're doing. People are impatient. They have no understanding of what it takes to do a data project. So I would encourage you, especially in new positions, work towards quick, early successes and ones that will generate upon each other and it'll make you look really good. May not be good like I'm not, but it makes you look really good. So I started on infant deaths. And you can see in Florida from 2075 to about 2005, all of a sudden we are starting to hit a nadir. And in fact, from 1995 to 2005, our rate, the red rate, is actually flat. If you use Joint Point, and that's one of the things you'll go over this week, it's a nice software, it was flat as of 1994, 1995. And all this problem they were having, well, our rate's going up and down, but we don't know what to do. It's like, because it's flat, guys. It's not because it's going up and down. It's essentially flat. And the state was doing better. And so in this, I started to investigate why. And the reason being is our birth weight specific mortality rates had finally plateaued. If you know anything about mortality, infant mortality, you can almost divide it up into prematurity and birth weight specific mortality. And that's a very nice way to divide it up. And when you do, you'll find out for infant mortality, it's improvement in birth weight specific mortality that's been dropping our infant mortality rate. And prematurity has not had a large impact on changing infant mortality. And so the primary engine for our improvement had stopped. And one thing I'm going to talk about next is quality improvement, which is why quality improvement now is an important issue in Florida, because we know our birth weight specific mortality rates are higher than other places, so we've not reached the quality that we need. And in fact, the rates are essentially the same. So we went through this whole process, and while doing that, Healthy Start invited me, since I was new back to the state, why don't you come talk to the state Healthy Start coalitions about what we could do to help on infant mortality, which was great. In Florida, we are different from most of you. We take a lot of our Title V dollars and our state dollars, and instead of funding them through county health departments, who are actually part of the state in Florida, we put it out to community organizations that are 501c3s. We put them out on contract, and they contract for services. They can't provide services, but they provide to others in the community, and they leverage those resources to get other resources. It's been an amazing strategy because it makes sure that our Healthy Start programs are community-based, because it's not the health department trying to work with the community, it is actually made up of the community. 2, whenever we go for cuts in the legislature, it's not about this state program. Guess who's sitting in the state legislators' offices? All these community-based organizations. So at times where the state budget got cut, Healthy Starts actually had increases because it's become an effective community-based organization. And so they wanted me to come talk about what Healthy Start could do. So I saw this as my opportunity to start thinking about the Healthy Start evaluation. Now, if you were put in charge to evaluate Healthy Start so that you could show how Healthy Start works, what would you think of that charge? They're not going to be happy unless you show them exactly what results they produce. That's exactly what they wanted. In other words, they wanted an evaluation done to document all their good. They started in 1991, and they were taking claim for all the improvement in infant mortality up to this point. And they were taking that to the legislature with all their amazing improvement they were doing. Now, how much improvement do you think community-based organizations have in birth weight-specific mortality rates? What? None? How many would vote on none? Most people would say absolutely almost none. So I did an important approach. I went in to talk about what's happening with infant mortality, what the drivers are, and then I showed them, who knows what Cochrane Collaborative is? They're the predominant group doing meta-analysis, and they're some of the leading groups in the country, in the world, doing meta-analysis. In fact, they've done 2 evaluations, one by the collaborative and one by an external group, and both documented high-quality meta-analysis, probably some of the best. And they had this statement about support during pregnancy for women at increased risk of low birth weight babies. Pregnant women need the support of caring family members, friends, health professionals. While programs which offer additional support during pregnancy are unlikely to prevent the pregnancy from resulting in low birth weight or preterm birth, they may be beneficial in reducing the likelihood of cesarean delivery. Well, by the way, our cesarean rate in Florida has just been going, so it's not helping with cesarean rates. So what does this tell? What does this tell us? Well, you can imagine they didn't expect to see this. And they were sort of surprised. And in fact, at that presentation, there were several different interpretations. One people said, well, Bill is saying that Healthy Start doesn't work. And others said, no, that's not what he said. He said, this article doesn't necessarily support it. What this did was it caused some discussions. It caused some consternation. But it finally brought home the point of we actually need to evaluate Healthy Start because it may actually not be working. The purpose behind this, and I actually talked about the themes in the program that they might need to address to make it better. And what it did is it started change. So now we wanted to evaluate Healthy Start. So we started a research committee to make sure Healthy Start were using the best evidence-based program. And we started an evaluation committee that I co-chaired for, let's talk about evaluating Healthy Start. Now, before I got there, they had been trying to evaluate it for a while. The health department had done evaluation, and one year it showed that it worked, And the next year it showed that it didn't work. What do you think happened to them? They were roasted. In fact, when they talked about doing another evaluation of Healthy Start again, they looked at me and go, not me, because they sat there in front of the 32 coalitions and were frankly roasted. And then they were accused of not being credible. So they attacked the messenger. So we couldn't do it. So they asked one university how much would it cost to evaluate them. This was this is around 2000. And they said only $2 million. Well, we didn't choose that option because we didn't have that much money. The coalitions decided to put out an RFP and invite universities to sign up to partner with Healthy Start and go after grants to evaluate. And actually, there was two universities took them up on that RFP. One did a really good one. And we actually spent money to help them pilot their design so they'd have pilot data. But we still couldn't find any grants to support it. So we started to review the literature, choosing critical articles that related to what we were doing in Healthy Start so that we had the best understanding of the data. So if we moved to evaluation, we knew what we needed to do. Then what happened is Medicaid had a waiver for Healthy Start. And by that, what they decided is it really worked. And so they were going to fund money as a Medicaid to expand it. And because of that expansion, they actually needed to do an evaluation. And they had one submitted. It was done by someone from the center that I now direct, who's not with us right now. And he's a lovely man, and it was a terrible evaluation. But it showed that it worked, so Medicaid was happy. I'm not sure how you could conclude that from what I read. And, but in there, he made this small recommendation. You should do an economic analysis. Well, the feds didn't require it. But for some reason, the agency said, well, maybe we should just do that. And so they approached us when I got there, say, now let's do this waiver, and let's look at the economic side. So Betsy Shinkman, with leadership from Stephanie Steris and John Corella, actually took on this evaluation. And they're good evaluators. And they said, we really can't do this without approaching the agency. So they actually invited us to collaborate with them in the actual evaluation. One, they didn't know perinatal data like we did, and they didn't know our data sets as well. And so it made for a good collaboration. Now, they would not let the full evaluation committee that we established work on that group. But we sort of shared what was happening so that no one was left in the dark. So they did their evaluation. At the same time, we also did an evaluation. And what I want to do is present some of the results to you. But more importantly, then I want to discuss the results and how do we use them. Because again, our talk is about use. Again, Healthy Start, does it work or not work? The previous evaluation, the idea of looking at it being used and not used in a population creates bias. So what they wanted to do was take high-functioning Healthy Start coalitions and low-functioning coalitions, which is a classic evaluation, and say, okay, we have better results in the high-functioning areas than we get around the selection bias of who participated in the program. I'll come to your question. At the same time, we actually had them look at those who got services and didn't get services in both of those groups. So we actually had 3 groups. Yes, ma'am. That's a good question. We went to the program and say, okay, how would you all, with your data that you've been collecting for so many years, I didn't say that, but how would you say which ones are functioning better in the model of what you're offering? And guess what? I got a blank stare. Well, we have contract data, Bill. We actually don't look at how well they're functioning. They just have certain contract parameters they have to turn in. So we actually had to come up with what are the better functioning groups. I'm going to walk through that. Again, what we decided to do was to look at all women who got Healthy Start coordination and those who did not. You had to be singleton, covered by Medicaid, Healthy Start. But what we did is we looked at a variety of benchmarks of what we thought a functioning unit would be from the data, Megan, that they had available. Because they hadn't defined it. So we had to define it. We looked at 6 different methods. And the 6 different methods we chose, the 8 low ones were always the same. And 6 of the high ones were always the same, no matter which method we chose. So we figured out it really didn't matter which method we used for high benchmark. There were really differences. We looked at intensity of services the woman got, proportion of women who got served, and a variety of those factors. So we ended up having 3 comparison groups. Healthy Start women in high benchmark coalitions, low benchmark coalitions, those in high benchmark who had Healthy Start and those who didn't, and low benchmarks who had Healthy Start and those who didn't. So we had 3 groups. Why 3 groups? You know, with EPI, when you're doing an observational study, the biggest thing you worry about are biases. So by having different groups, we're trying to see if we have consistency of findings. We ended up having 4 time periods. We had the pre-waiver, the first year of the waiver, and then we took the southern part into 2 periods. The reason being is we've been doing the waiver so long, we wanted to see what the initial impact was, and then was it sustainable. I don't need to go through that. I'm going to show you this graph here so that you know what a good result would look like, because I'm going to show you a variety of graphs, and I want you to be able to quickly see a pattern. Okay, you have the pre-waiver period. However, Healthy Start was occurring before the waiver. So we knew that there should be some benefit from just doing Healthy Start. So the pre-waiver should show something slightly better, and then with each year it should get better, and a star should be significant. Okay? So with each line, 0 means this is neutral, down means better, and the further down you are, the better it is. You got that pattern? Let's walk through some of the results quickly. This is the percent preterm births in the 3 counties. Are you convinced? Not very conclusive. Here are the percent of low birth weight births in the 3 comparison counties, and it's all over the map. Here's the percent of small for gestational age births. Here's the percent receiving timely prenatal care. Now you have some effect here, but you have almost the opposite in the other groups. Here's percent receiving postpartum care. Now here's some nice clear trends. Differences in just expenditures for prenatal period. But what's the problem with this graph? It's the wrong direction. However, I would argue it's the right direction. The whole idea of Healthy Start services was to get them in prenatal care and get them the services they needed. Those services cost. Medicaid pays for it. So, and in fact, what you would argue is they are working on the process piece. And this is showing what you would want to see. Now, on the expenditure piece, actually, the results look much better. However, notice the benefit is going down as low as 500, and the costs go up as much as 600 to 1,000. So it may be costing more than it's saving you. Oh, I went the wrong direction. There it is. It's costing us somewhere between 500 to 600,000, and the benefit is somewhere between 500 and 200. And then if you look at infants, it's all on the more expensive side. Of course, again, Healthy Start's helping those infants get services, so it's going to cost them more. So it was hard to conclude. There are limitations: observational study, secondary analysis, statistical power, linkage, reporting. There are limitations. There are strengths. But the conclusion is it does not appear to be impacting birth outcomes and it's consistent with the literature. However, there might be some cost savings, but it costs more than it benefits. Now, what we also did an evaluation. One of the big problems I have with infant mortality and prematurity is it's a complex medical social outcome, and a lot of factors affect it. So if we're going to have a program affecting it, it should be doing it through intermediate outcomes. In other words, I should be looking for things that should be changing before those results because it's more easy to show those. To do that, in the past, what they did in the Healthy Start earlier evaluation, they took screen and services and looked straight at outcomes and costs. What we did is we added in intermediate outcomes and we used PRAMs. And because Healthy Start is so prevalent across the state, with multiple years, we actually had enough participants to use our PRAMs data to look at intermediate outcomes. So we did the same type of evaluation and looked at intermediate outcomes. And here are our questions. We looked for adequate prenatal counseling, prenatal WIC participation, gestational weight gain, NICU admission, postpartum contraception, a health provider in the first week, breastfeeding, sleep position, passive smoking. Merged data files, you saw that. Again, we looked at those women who had Healthy Start coordination, those who had other Healthy Start services, and then we looked at those who had none. We were going to drop the other because it doesn't add any information. And then what we did was we had 2 reference groups. Among those screened, we had those who had no services. But our second reference group, what we did is we used PRAMs as our screen and looked at those who didn't screen and used PRAMs to pick up those who didn't participate so that we could understand what happened there. So we had 2 different reference groups that got away from, and one of them got away from selection bias. So 2 groups, one Healthy Start Coalition, no services, one Healthy Start Coalition, and the other women not screened. Here's our results. We had slightly more adequate prenatal visits, which is good. That's not necessarily a definitive outcome. Prenatal counseling. PRAMs looked at 11 different measures of counseling. On average, women who had Healthy Start had 1 additional counseling, only 1. Very small improvement. They had about a 5 to 8% improvement in prenatal WIC participation. Again, fairly small. They did slightly better at breastfeeding initiation and slightly better at breastfeeding duration. There was no improvement in weight gain, inadequate weight gain, no improvement in excessive weight gain, no change in NICU admissions, no improvement in postpartum contraception, no improvement in health provider in the first week, no improvement in back sleeping, bed sharing, or passive smoking. None. How many of you in this room would like to share these results now, combined to the 32 Healthy Start coalitions? Anyone want to volunteer in the room? I actually got invited to go do that. But, guys, I'm smart enough to know I don't want to walk into a room and just give them data. That doesn't lead to results. So what do we do? Well, the evaluation committee. Well, guess what we did? We started to update the evaluation committee with the results as they started to come out. So we knew 6 months ahead of time of when we were going to present. It takes a long time to wrap up results. But we knew what they were coming. And so they had the idea of the notes. And believe it or not, the Healthy Start Coalition said, we guys need to meet. So the leadership came and we met together and we talked. And we said, you know what? We're not doing well as an evidence-based program. And these evaluations show that we need to change. And so at the same 6 months we were wrapping up the evaluations and preparing the presentation, the leadership in the health department developed a plan for change for the program. And what might that look like and how might we do that? So that when we went into January and presented these results, we not only focused on the results, but we were ready there to talk about the need for change and how that change might take place. Now, believe it or not, there were leadership people who already knew what the results were going to say, and they just looked at this bill and go, it took my total breath away. But you got to understand, some of these women have been working on this program for over a decade. And they are believers in this program, and they've been going to the legislature selling this program, and this was not the type of results they were wanting to see. However, I will also tell you that they had to have a family meeting, and as some would say, come to Jesus meeting, and talk about what needed to happen. Because there was a third of the group who said, we need to change. And the middle of the group was going, yeah, it sounds like we have some issues. And the third group says, we don't need to do anything different. We should just keep doing what we're doing. And absolutely want to change. I said, why? The legislators are supporting us. We have our money. Let's just keep doing what we're doing. Again, you'd be surprised. There's a lot of people out there. So what we did was they talked about it, and then we came back and talked about a change strategy. And so they're now, and over the years, working through a change strategy of Healthy Start to have it be more evidence-based. But what am I trying to say? The key here was not us evaluating Healthy Start. The key was moving to the results we wanted. I need to make sure they started out with the right question. Does Healthy Start work? We need to start at the right place. We need to have a group, an evaluation group, to help make sure that when we look at this, we were credible. And what we were doing was not off in our own room, but we were leading the change. And three, when the results were starting coming out, we didn't just stop with, here are the results, good luck to you. In fact, when we did the question and answer period, the leadership sat and answered questions about the study and what we were going to do, and not me. Now, if there were technical questions, I answered questions about this study, but we had the focus be on their peers so that the interpretation and other pieces were from trusted sources and not, so that shooting the messenger was much harder. So I want you to know the process was about a change process and not just the results. Yes?
I was just wondering from a communications perspective, a lot of the women that are certified Healthy Start and other community-based programs are certified other programs as well. And during your planning, how did you address the attribution question? How do you attribute some of the results that you were going to find to Healthy Start versus?
Well, again, when we talk about this Healthy Start here, and I wasn't clear, and I apologize. There's the federal Healthy Start, and then there's our Florida Healthy Start. And our Florida Healthy Start, as I described, is in all counties in Florida through 32 coalitions. And so there wasn't a certification. But I will also tell you that the Healthy Start program at this time was not exactly the same in every county. There were certain contract parameters that were the same, but everyone was doing their program somewhat differently. So it made it a challenge. And that's why the low benchmark and the high benchmark was helpful, because it let us look at those who were potentially going to have the greater results. But when they didn't have better results, it took away that argument. Other questions? So I used this. This was a political hot topic, had great impact, the largest program within our budget. But the key get to be is we had to set it up right. We had to have the right people at the table. We had to think about the end result in the long run. And we had to do the steps in a way. And if you can deal with political topics that are highly controversial, that have great stakes. But developing all those pieces are critically important. We are now at a break time. I'm happy to talk with other people if you have questions afterwards or into our next talk. Thank you all.